So, a little bit of background on why we're having this conversation, where we're coming to this from, and then I'll let Dr. Ghosh introduce herself too. I am Rebecca Medansky. I'm a pelvic floor physical therapist. I work in Austin, Texas, and Dr. Ghosh was actually my OB when I had my baby 5 months ago. And she's a good friend of mine. And I've been having a ton of conversations since 2022 with my patients and also with friends, since I have a lot of friends having babies right now about what the state of reproductive health is like in the United States right now, particularly in states like Texas where there's an abortion ban. And though not a whole lot has changed for us since last week, it feels like this fear was kind of renewed and reignited since the election. And so Dr. Ghosh and I were actually already planning on doing a webinar on a separate topic and decided that this actually seemed to be something that people were more interested in right now. And it seemed a little bit more pressing and appropriate for what's going on in the world.
The elephant in the room was just a little too big to ignore.
Yes, for us to have a pain with sex webinar, which might be coming at a later date anyway.
Right. Like, put a pin in
Um,
it.
so that's who I am. But I want Dr. Ghosh to introduce herself as well. And I also just wanted to say thank you so much to her for her willingness to have this conversation with us because Dr. Ghosh is a board certified practicing OBGYN in the state of Texas. That's where she's coming to this from. She's not an attorney. She's not speaking as an authority on the intricacies of the law right now, but she's speaking from the perspective of somebody who's been navigating these legal repercussions for the past couple years. And so I'm going to have her introduce herself, and then we're going to get started with kind of some background on how we found ourselves here, and then we'll dive into those questions.
So I'm Romy Ghosh. I am a board certified OBGYN. I am from Texas. I moved to Texas when I was 6 years old. I did sixth grade uh, through high school in Austin. And then I did my undergraduate at Texas A&M University, where I got a biomedical science degree and I got a minor in women's studies. And then I went to medical school in Texas Tech in El Paso at the Paul L. Foster School of Medicine. And I also got my master's of public health at the same time. And then I did my residency in Tucson, Arizona at the University of Arizona in Tucson. And then I moved back to Austin in 2017 because this is where the majority of my family is, my parents, my brother, and my sister-in-law, and their four kids. I do have a sister who's a lawyer up in Seattle who I have been talking to sort of about these laws as they've been rolling in. So like Texas is my home. It's where my family is. It's where the vast majority of my friends are. So being and living and practicing in Texas is very much a part of who I am. And so I've seen the changes in Texas since I started practicing here in 2017. And yeah.
Thank you for that background. I didn't, where were you before you were six? Clearly the most important part of what you.
I was born in Illinois, actually.
I
That's where my parents were initially, and then we moved here to tech, obviously.
Obviously.
Yeah.
Okay, well, let's start with a little bit of background about Dobbs and kind of what the progression was, how we got to where we are today, and what that looks like now.
Yeah. Initially, the initially before SB4, SB8, abortion was legal in Texas. I think what it looked like maybe a little bit different than some areas is that sometimes it was harder to get access to second trimester terminations when we saw certain complications come up, but we had access to terminations up until viability. Then in 2021, I believe, SB4 and SB8 passed, which are Senate bills that passed through the state legislature that essentially said that once there was what they call a heartbeat, which is typically after 6 weeks of pregnancy, you could no longer do termination of pregnancy for any reason. And that in of itself was pretty devastating because most people don't find out they're pregnant or don't even get in to see an OB until about somewhere between 6 to 10 weeks of pregnancy, and for some offices, even later than that. SB4 has more to do with the ability to get um, abortion medications through the mail, I believe. Um, then fast forward to the Dobbs decision, which basically overturned Roe v. Wade. And essentially, what my understanding, again, as a non lawyer, is that it sort of struck down Roe v. Wade on the basis of the Roe v. Wade was based on the idea of that people have right to privacy, and it sort of said that doesn't really apply. And what happened once Roe v. Wade got overturned, a lot of states have what is called a trigger law. And a trigger law basically is a law that got triggered in the event that Roe v. Wade got overturned. They had these laws sort of already in place, sort of already set up that they could automatically go into place. And that's what happened. And that was with it's a House bill, and I don't remember the number. But essentially, what it did is it criminalized any termination of pregnancy that occurred after conception. And they very explicitly, because I read this morning, it defines conception as when the sperm penetrates the zona pellucida. Okay, so it's very specific in its wording. And the penalty is not for the pregnant person, but for the provider who does that termination of the pregnancy. And so the penalty for that is up to a lifetime in prison, $100,000 fine per offense, and loss of your medical license, which are three things that will basically ensure that you probably will never practice medicine ever again. And so that put essentially a near total abortion ban in the state of Texas. And that abortion ban did not have any exceptions for sexual assault or rape or incest. And the only exception is for life-threatening situations as it applies to the mother, though that is not well defined in the law.
And that seems to be kind of the root of a lot of stories that we're seeing coming out in the media now that have occurred over the past couple of years. But before we move on, and I know that this might feel kind of obvious for a lot of folks listening, but I don't think that it's obvious for everybody. Can you define what abortion means?
So that's kind of, I mean, it's both an easy and a hard question to answer because I think abortion is such a polarizing term for people to use. But miscarriage really isn't a medical term. We use the term miscarriage because I think it is because we've polarized abortion so much that it's a softer way of saying abortion. So an abortion is any sort of termination of the pregnancy, whether or not that is spontaneous, whether or not that is elective or therapeutic. An abortion is a stopping a pregnancy for whatever reason. And so when we talk medically with other medical providers, if someone has a miscarriage in which they've come in, they've gotten an ultrasound done, and there was a heartbeat before, but there's no heartbeat anymore, we call that a missed abortion. If we have someone who is their cervix is open and bleeding and there's still a heartbeat, we call that an inevitable abortion. If we have someone that has partially completed passing a pregnancy, but there's still products of conception still in the uterus, we call that an incomplete abortion. If we have someone who has had an elective termination, we call that an elective abortion.
Okay. And I mean, that's really clarifying. So thank you for that, because I think a lot of people, at least the media portrays it as a people assume that an abortion is an elective termination at a certain point in pregnancy. And that's not what it means. And I think that's where a lot of this controversy and also kind of confusion comes from for people.
Yeah.
So let's let's maybe start with, I'm trying to decide what order to go in, and this is probably something that we should have decided on before, huh? But
I
but
think I think maybe you could well go ahead and use it.
no, if you have an idea, if there's something that you want to.
My thought is to sort of walk through what a pregnancy looks like in the first trimester, what a pregnancy looks like in the second trimester, and what a pregnancy looks like in the third trimester.
Let's do that.
Um, And then I think one more thing, I think, as far as a clarification for when we say the term elective abortion, I think when people hear the word elective abortion, I think what most people sort of thought is there that's someone who is the vision that usually goes up into people's mind is they're young, they got accidentally pregnant, and now they're electing to terminate that pregnancy, and it's a healthy pregnancy, whatever. That is one type of elective termination. Elective in surgical terms means that it's not life threatening at the time, meaning if you have a major medical condition that is contraindicated for pregnancy, even though if that pregnancy is not going to be harming you then, but could harm you in the future, most of us may recommend doing a termination of pregnancy. However, um, that's considered elective.
Sure.
If you have a pregnancy that's affected by a anomaly of the baby or the fetus that is incompatible with life, terminating that pregnancy is not considered medical. It's considered elective, and I think that's an important distinction to make.
Yeah, I think that that is a really important distinction to make, and I'm glad that you said that because you're right. I think a lot of people are thinking about folks who are using abortion as birth control, which is one way abortions are done, but it's not the majority of them.
Yeah,
And I know for me and for my patients, because I am a prenatal and postpartum pelvic floor physical therapist, the majority of the patients that I'm having these conversations with desperately want a pregnancy. They're either trying to conceive, they are pregnant, they have planned their pregnancy, they've desired their pregnancy. And I'm not saying that that's the only reason why somebody deserves medical care, but it is kind of it's a fork in the road from where people are imagining this kind of scenario affecting people. Um,
yeah.
but yeah, let's walk through pregnancy, then let's walk through kind of the
And I
stages.
think, and just, I think one clarification that I want to make about how I practice is since moving to Texas, I have never done a truly elective termination of pregnancy. All the pregnancies that I have been involved with that involved termination of the pregnancy has only been for medical reasons. And so I want to emphasize that those laws have affected my practice, even though I do not do those. I have not done those types of terminations since coming to Texas. Now, part of my training was doing elective terminations of pregnancy for people who were electing not to continue pregnancies for whatever reason. But since coming to Texas, despite the fact that I don't do those types of terminations, these laws still affect me and still affect most generalist OBGYNs.
And just because this question clarifies what we're talking about right now, somebody asked in the chat, is it still considered an abortion when the baby isn't viable?
So it depends on what you mean by isn't viable. Okay. If you, and I will talk in terms of what the law says versus sort of what medically we think of it. So if you have a pregnancy, and I guess this sort of jumps into their sort of discussion about first trimester. So let's say you're in the first trimester and you come in and you had ultrasounds, you were 8 weeks pregnant, things look great. You came in, we did a 12-week scan, which a lot of us are now doing because of these laws. We did a 12-week scan and there's no longer a heartbeat. I can intervene with there. There's no contraindication to me from a legal standpoint, from me being able to intervene with a pregnancy where there's no longer a heartbeat. Now, let's say that you came at 12 weeks and your baby had what appeared to be some sort of potentially lethal anomaly. Let's say that we did an early scan and we were concerned that there was a condition called anencephaly, meaning the baby doesn't have most of its brain from the ears up. Okay. That is not a reason. That would be considered an elective termination of pregnancy. That's a non-viable pregnancy, meaning it's not a pregnancy that's going to lead to a baby that has any sort of like long-term life. So some babies with anencephaly can be born alive, but they don't typically survive very long. But there's no longevity. Okay. That type of pregnancy we cannot terminate in the state of Texas.
Thank you. And I see a lot of questions that are kind of dancing around this topic, but let's save them until the end because I think that we're going to answer a number of the questions, a couple of the scenarios that are popping up as we go, but we'll come back to them at the end as well, and we'll kind of call for new questions to come in also.
And because there's a lot of people who are here from out of state, I'm talking about the laws in Texas because those are the laws that I know, and it's really hard to speak to each state in which there are different laws that have different restrictions on abortion. That's going to look different in your state. And I encourage you, if you have concerns about that, to reach out to your OB, to your midwife, and see what are the laws in your state and what are the restrictions based on that.
And we'll talk a little bit about questions that people can and can't ask their OBs towards the end, in
Yeah.
case you're wondering what specifically to ask. But let's get into pregnancy and what that looks like through the first, second, and third trimester in Texas.
Yeah. So pre row slash SB4 slash SB8. If I had a patient that came in for their first trimester discussion, so they came in for their new OB visit, I usually get and I still do, I give a pretty detailed discussion about sort of genetic testing because that's sort of the first point. And there are typically three genetic conditions that we look for right off the bat. Okay. Now, most of this genetic testing cannot be done until about 10 weeks of pregnancy. So that's a really important thing to know. The testing is not validated any prior to 10 weeks. In fact, if we send it prior to 10 weeks, they send it back saying we can't run this testing. And the more invasive testing for genetic testing usually can't be done till about 12 weeks. That's called a CVS sampling. Okay. So I usually typically will have a discussion with a patient about here's what we are looking for. Here are the three conditions that we're looking for. And the three typical conditions that we look for are trisomy 21, which causes Down syndrome, trisomy 13, which causes Patau syndrome, and then trisomy 18, which causes Edwards syndrome. Most people have heard of Down syndrome. And I think a lot of people oftentimes think of Down syndrome, and maybe this is just my perception, as a more of an intellectual disability. However, Down syndrome actually has several really severe anatomic issues that can come up, including severe heart issues that require a lot of cardiac management and specialists. And the other two conditions, trisomy 13 and 18, can lead to pregnancies that progress into the second and third trimester of pregnancy, but are not considered to be viable long-term, meaning these babies, if they're born alive, which oftentimes they're still born in the second and third trimester, if they're born alive, they really don't live very long. And we tend to do supportive comfort care when those babies are born because the anatomic issues that come up are usually so severe that they're just not compatible with life long-term. And so we do that genetic testing. And it used to be when I gave that talk to patients, and I would talk about why would we do genetic testing in the first place? Well, what is the benefit of doing genetic testing? The first thing I would say is we do this genetic testing because it allows us to be prepared, right? If you knew that you had a baby that would potentially be affected by Down syndrome, we'd want to send you to a high-risk OB doctor to look for those potential heart issues that potentially could cause issue and potentially need surgical intervention. And then for trisomy 13 and 18, we'd want to be prepared for a pregnancy that's not going to potentially even make it to term. And the vast majority of those patients end up having stillbirths in the second and third trimester. So the other option that I would have presented to them is that if these came back abnormal, one of your options would be to consider a termination of pregnancy. Because for a lot of people, it is more straining and stressful, the idea of carrying a pregnancy into the second and third trimester that we know is going to pass upon birth. And a lot of people, for wanted pregnancies, would say, I'd rather my baby pass with me and then move forward that way and reduce risk with being in the second or third trimester with having a pregnancy. So typically what would happen is in the first trimester, and this is what we still do. We get an abnormal genetic testing screen. And the screening that most of us do nowadays is something called cell-free DNA testing, which I could have a whole other chat about. But that testing is not considered to be a diagnostic test. It does not diagnose these conditions. So then typically what we do is if people are wanting to make decisions, we send them off to a high risk OB doctor or a perinatologist. Some people may know them as a maternal fetal medicine or MFM doctor. Those physicians are able to do the more invasive testing to get the better answers as to if that is a true positive or a false positive. Um, because the testing is not 100% accurate. And so then you're sort of having to make these critical decisions that are pretty life changing based on like data. And so what I have seen post Roe is people not wanting to do sort of saying, hey, I'm going to go out of state and not doing any sort of follow-up testing because that testing takes time to do.
Um, that is a really helpful walkthrough. And to be clear, I mean, that means that at this point, and I think that people, when they're imagining how Dobbs is affecting, how the dismantling of Roe is affecting pregnant people, they're not imagining the scenario of somebody who really wants this pregnancy. And again, I'm not saying that that is the only time that somebody deserves health care. But I think that they're not able to imagine the situation where somebody who really wanted this pregnancy is now in the situation where they're being told that their pregnancy isn't going to either make it to term or they will give birth to a baby who won't survive.
Yeah.
Um, and I mean, just to summarize what Dr. Ghosh is saying, this essentially means that if somebody's getting positive testing and they know that their baby isn't going to survive upon birth or possibly even make it to birth, they don't have the option to remain in state and do anything about that, which is obviously an incredibly painful and very scary place to be.
And one of the sort of stipulations of SB8 is I most of us feel that the First Amendment protects our rights to be able to discuss at least the options with our patients. However, we cannot, the law sort of prohibits us from aiding or abetting. So SB8 is sort of on top of the trigger laws that are in place. So SB8 essentially it's a civil lawsuit. It's a $10,000 fine to anybody that aids and abets someone that gets a termination of pregnancy. So I can tell you what your options are. I can tell you they're not available in Texas. I cannot tell you where to go or what I cannot help my patients in that way. And I think that has been one of the most frustrating things about these laws is that you truly feel in a lot of ways that your hands are tied when it comes to those situations.
Well, and I'm sure the people listening can hear this hesitancy even in your voice just discussing this in a
Mm-hmm.
non-medical platform. We're not in the clinic. We're not your
Right.
patient. I'm not asking you how to manage a pregnancy that I want to terminate. We're just
Yeah.
discussing the legality of discussing what happens in these situations. And
Right.
even in this situation, you're hesitating to say things and you're being really intentional about the way that you say things. And for those of you who are listening and who haven't gone through a pregnancy since this has changed, or haven't seen your OB since this has happened, or are not living in a state with an abortion ban, I mean, this is also what OBs are facing in the clinic. And this is also what their patients are seeing in the clinic also, is that their physicians are nervous to be physicians and to speak candidly. And we already know how difficult it is for patients to trust medical providers and for them to feel really comfortable in the care that they're getting. I mean, medical providers, MDs, physical therapists, all of the above, we spend so much time and put so much effort into presenting information the right way and making sure our patients feel seen and heard and supported while giving them actionable and I mean, accurate information. And so it's just seeing how hard it is to discuss this candidly and knowing how that applies to
Yeah.
clinical care is really tough.
Yeah. So I do want to reassure people. before I get too doom and gloom, because it's not just, I don't want to be too overly doom and gloom. I don't want to be too overly rosy. I think I want to be realistic. If you have a diagnosed miscarriage or spontaneous abortion, I can treat that. If ACOG, the American College of OBGYNs, they have a list of criteria that tells me that I can diagnose something with a miscarriage. Because sometimes it's not always cut and dry. If I have a patient that meets that criteria, I can move forward with giving you medication. I can move forward with doing surgery for you. I can manage that, and I can manage the complications of that without problem. If you have an ectopic pregnancy, if a pregnancy is located elsewhere other than the uterine cavity, the law also does not say that, like the law does allow me to intervene. Um, so I want people to know that those things are not prohibitive. And I know that it can be scary because we see these news stories about people whose miscarriages and ectopic pregnancies were delayed in their care. I practice at a very large hospital in Austin. I practice at a hospital that is what's called has a level 4 maternity care and a level 3 NICU. We have access to all the specialists. We have access to anybody that I would potentially need for complications in pregnancy. I can imagine that not having access to those resources would make it harder for someone to act appropriately in the management of a pregnancy if they don't understand how the law works because they haven't come across those situations quite as commonly. The volume of patients that my hospital takes care of is very, very large. Not quite as much as like Parkland and Dallas, because that's 12,000 deliveries a year, but we're getting pretty darn close to that. So I think that being well supported, I have felt well supported making decisions that I've needed to make in regards to some of this stuff. But I can understand if I wasn't in the hospital system that I worked at, that might be more difficult decision making.
So I see this question kind of coming up in a number of questions in the Q&A and different variations of this. So what can you kind of walk us through, and you alluded to it, but can you walk us through what's happening with these obviously with limited information, but with these stories that we're seeing, and the stories that the two that have come out recently are pregnant women who are going to emergency rooms, they're bleeding, they're pregnant, they are in some cases being diagnosed with spontaneous miscarriage, and yet they're being sent home. They're not being admitted. So what do you think is happening there? And why do you think that's happening?
I think confusion is happening. I think if someone came to my ER and let's say they had a first trimester pregnancy loss, it's cut and dry if there's no heartbeat. There's no heartbeat. I need to be managing that patient appropriately. Um, Again, I know that because am faced with the realities of this law all the time. Um, it becomes a little bit more dicey if there is still a heartbeat. And sort of we're getting into sort of the end of this first trimester, second trimester complications that really is where these laws seem to be the issue. Because to fast forward a little bit, when you're in your third trimester, or really just any point past viability of pregnancy,
Which is how many weeks?
depends on the hospital that you're at.
Okay.
So our hospital is able to resuscitate, is able to offer resuscitation down to about 22 weeks of pregnancy. Outcomes are better after about 20, like significantly better after like 22 to 23 to 24 weeks. It's in that period before viability that it becomes an issue. Because if you're viable, then we can say, well, we can deliver the baby and then we're able to take care of mom and baby separately, right? It's in the second trimester that we come across these situations where we get into this gray area that can be a little bit more difficult to take care of. So I'm going to bring up a hypothetical situation. I'm not going to talk about any personal cases. I'm only going to talk about hypotheticals because that is to protect myself. That is, but mostly, obviously, to protect my patients. But let's go through a situation in which, let's say that you were 18 weeks pregnant and your highly desired pregnancy, you break your bag of water. Okay. Break your bag of water, you go into the hospital, they determine your cervix is not open, it's closed, you're not in labor. Okay. You're not, your body's not trying to contract out the pregnancy. Okay. Pre-row balling, pre-Dobbs, what we could offer is if a patient came in with their bag of water broken, we could offer essentially either a induction of labor, meaning to give them medications to pass the pregnancy, or in some cases we could offer what's called a D&E. And the reason that we have these medical recommendations is because when your
What's
bag
a
of
TB
a
before?
D, yeah, a D&E is a dilation and oh my gosh, extraction. It's basically like a DNC except for further along pregnancies.
Mhm.
Um, then if that's not the right, if that's not what the E stands for, I apologize. I'm a little nervous. But the the rationale for wanting to do that is because if at 18 weeks your bag of water breaks, there is a high likelihood that even if we're able to keep you pregnant all the way to 34 to 37 weeks, which is how long we try to keep patients who break their bag of water early, that there's such a high risk of you developing an infection. There's such a high risk of your baby being unable to develop their lungs because in order for a baby to develop their lungs, they have to have fluid around the sac. And if they, let's say that they're unable to build up that fluid back in the sac, they will not be able to develop their lungs because they practice babies, fetuses practice breathe. And so the inability to sort of inhale the fluid prevents their lungs from being able to mature. So even if you're able to get the baby to a more viable gestation, the likelihood of your baby being able to survive is so low. Because as much as we want to believe that medicine has taken us so far, we still have so far to go before we can remedy some of these issues. And so pre Dobbs, we could offer an induction of labor. Now it's a gray area because there is such a high risk of infection, but that patient may not be infected yet.
Mhm.
So at what point does that pregnancy become life-threatening to her? She may never get a fever, or she could get a fever in the next couple of weeks or in the next couple of days. And if she does get a fever, how quickly does she go from just having a fever to becoming incredibly ill?
Mhm.
I think one of the cases that came out of, I think it was Houston, was the patient who was around 17 weeks pregnant. Her cervix prematurely dilated, and her bag of water was what we call hourglassing or sort of bowing into the vagina. And unfortunately, the vagina has a lot of bacteria in it. And so she probably at the time was not having fevers. And I'm just conjecturing. I don't know the specifics of the case at all. I don't know anything about her care. So I'm just conjecturing here. I'm trying to think of the scenario in which this would happen. But if they felt like they couldn't intervene because there was a heartbeat, that bag of water could have been exposed. And there are infections that can become very aggressive very fast that could potentially have led to the outcome that she had, where she got infected after having her bag of water exposed for 3 days on end. And then getting a fast infection that ultimately was very difficult to treat once it got to the point that it did.
And at that point, that patient also is, I'm assuming, unlikely to be safe to get on a plane and travel out of state if that's even an option for them. Is that correct?
Right, exactly. Like that's not like if I had a patient in the hospital, it would be I mean, it would almost be an EMTALA violation to tell them get in your car and go out of state, because they are at such risk of doing it. I mean, it's hard to be in those scenarios and to watch that happen.
Sure, I'm sure. And so in the first trimester, I mean, and despite the spontaneous miscarriage can happen at any point in pregnancy, particularly in the first trimester, it's relatively common. But in the first trimester, it seems like these cases that we're talking about are, okay, we get the information that the pregnancy isn't viable or the fetus isn't viable, the fetus is unlikely to survive or to make it to full term. So in that case, there might be this window where it might be safe and appropriate for somebody to travel out of state if that is what
Right.
they're.
Yes. Yeah.
And as we get into second trimester, we move into this place where the reasons why somebody might be having a termination now also prevent them from traveling. And that's where it seems like a lot of these scarier stories and cases are coming from.
Yeah. And like I said again, I'm very, very privileged, and I think my patients are very privileged to be able to be delivered at this hospital because we've sort of developed a process. We have a lot of physicians that are available in which if we find something to be life-threatening, we typically will consult with a high risk OB doctor who will essentially give a second sign off to say, yes, we think this is life threatening enough to move forward with terminating the pregnancy. Or, and again, to emphasize, the only pregnancies I'm working with are pregnancies that are very much desired. And I, I think that I don't think that any physician is intentionally trying to not care for patients. But I think people who feel threatened don't make good decisions, or they cannot make decisions without. I'm trying to word this in such a way that makes sense. I think I've told you this before, Becky, that like these laws feel like someone's putting a gun to your head and you're trying to make decisions.
I was gonna say, I mean, the threat of $100,000 in loans and the loss of your license and jail time, like I don't think I could send an email with that pressure riding over my head. Like
Right.
we're expecting physicians to make life-changing decisions with that kind of pressure. And so, yeah, it makes a
And
whole lot of sense.
and as you said before, medicine isn't black and white. It isn't this, if then. I mean, there are so many shades of gray to what we do. If it were that easy, I could just put something into a computer and it would tell me what I should be doing. But that's not the reality of the situation that we're in. And I think sort of what I see as the biggest issue with these laws is that it creates, to me, a direct conflict of interest between the physician and the physician's livelihood and then your patient's livelihood, which is just so out of pocket. Like that's not what we went to medical school for. And there are so many criticisms that we could have of the medical system and physicians and obstetrics in general, and how we could be doing better for maternity care for so many people. We could be doing so much better, but laws like this are not going to make anything better for those people, and especially those people who are disadvantaged in the system.
Right. Well, one thing that we talked about on our phone call when we were originally deciding to discuss this is who really is going to be most affected by these laws and who's going to bear the brunt of the suffering as a result of these abortion bans. And it's not most likely to be the people with good prenatal care and the people with access and the people who live in major cities who have the ability to get to care really quickly. It's most likely to be the people who are already experiencing the worst maternal outcomes and the worst
Right.
maternal morbidity.
I mean, I think in Texas, if you've been following I think that like there's been legal cases and whatnot. You can certainly follow that. But some of the cases where women have died, it is unsurprising to me that they have been women of color. Unsurprising.
Can you
We
talk a little bit as to why, for people who are wondering why that's the case?
That is a loaded question,
It is.
Becky.
I know it is.
Um, I mean, those are people who traditionally oftentimes have poor access. And they're also working against a system that has disenfranchised them to begin with. And they're dealing with a system that has traditionally not listened to them when they have had concerns about their own health. Now, add to that the layer of your physician now being scared to take care of you or being concerned that if they take care of you in the way that they think is proper, they might go to jail. That does not lead to better care for those patients.
Right. Right. And I know that, I mean, a lot of people I see in the chat are talking about like they're talking about a pregnancy, they're talking about wanting to try to conceive, they're talking about being scared about being pregnant. What would you say to somebody who lives in a state with an abortion ban? And I mean, I've had a lot of these conversations with my patients, and we are talking about privileged people for the most part in the discussion that
Yeah.
I'm about to have. What would you say to somebody who's thinking, I need to leave this state to be safe through a pregnancy? And that's also, I mean, that's a tough question to answer.
Yeah.
That's not like a black and white interpret the law for us. It's a little bit of a softer question, but
Yeah. I can tell you that I feel like and because I can only, I don't want to minimize the fears of the people who are trying to get pregnant because I think their fears are absolutely valid. That being said, I felt like I work with a group of a total of 6 OBs and 2 nurse practitioners who are some of the most amazing OBs that you will ever meet. And I feel so confident in our ability to take care of patients, on our ability to intervene. And we have appropriately, and I believe that we've prevented poor outcomes. And so I think that if you are considering getting pregnant in Texas, I think having a conversation with your care provider about what we can, like what we can and cannot do, we can and cannot discuss, your fears about your pregnancy, knowing what your individual risks are and potential complications that could come with your specific pregnancy, I think that is going to go a long way because I think the vast majority of my patients who have given birth, even in some of the highest risk pregnancies, um, I've been able to get them safely through their pregnancies and their babies safely through their pregnancies. Um, am I worried at some point that there's going to be a statistic? Sure, always. But I, my job, my entire job is to try to keep my patients safe and to keep their pregnancies safe. And I will do the best that is in my power to make sure that happens. And I feel well equipped in the facility that I work at to take care of patients in the way that I see best. There are a lot of things that are out of my control, and that is unfortunate. And I wish that things were different, but I do feel that the vast majority of pregnancies are going to be okay. But I
uh,
also understand the hesitancies.
yeah. Yeah. I mean, Dr. Ghosh and I have had this conversation a bunch of times from a bunch of different perspectives. And I think the unfortunate reality is it's hard to say anything that is so incredibly black and white comforting. And also, there is a lot of fear out there that's very much so justified. And we're hoping that this information helps people kind of find a better balance of how to navigate kind of like a lot of the very scary things that they're seeing online.
Yeah.
Um, so say somebody, and actually we got through the first trimester, we talked about the second trimester, you sort of high-fived the third trimester saying that when somebody gets to the point of viability, they can be delivered. But can you talk a little bit about what life-threatening conditions can arise in the third trimester and how those are managed?
Yeah. So the vast majority, so the when we look at sort of life-threatening things or things that increase maternal morbidity and mortality, it's going to be preeclampsia. It's going to be hemorrhage, bleeding, and it's going to be peripartum cardiomyopathies, which kind of comes out of left field. Nobody ever talks about it, but that's so basically maternal heart conditions that arise or are exacerbated by pregnancy. So those are the three big things that can potentially be harmful. At a facility such as my own, being at a maternity level 4 facility, we deal with those situations on a daily basis. Our nurses are fantastic. If any of you guys are here, shout out to the nurses at my hospital. You know who you are. But they are phenomenal about having protocols to treat and manage those things. Just like even in the past, I want to say 2 months, I probably dealt with 2 massive hemorrhages in which we were able to very swiftly and promptly take care of patients. Obviously, some trauma involved for those patients, but they ultimately survive those conditions. But those kinds of things, again, are bread and butter. I think for those who are worried about pregnancy complications, it's obviously harder if you live in a smaller city with a smaller hospital. I think asking your OB or your midwife in those situations, hey, what happens if XYZ problem arises? What is your like emergency management plan? Our hospital is sort of one of those end of the line hospitals, meaning like we are the hospital that people transfer to. So we have access to all the resources for which I am so incredibly grateful that I do. Shout out to the OBs who work in less than ideal circumstances. They tend to be amazing OBs because they have to know the difference between when to transfer and what they can deal with at their hospitals. But I think talking with your OB about like, what is the contingency plan? What happens if I develop a complication, in the end of my second trimester? Like, where will I get transferred? Can I stay at this hospital? If I transfer to that hospital, does my baby get separated from me? If they have to go to a higher level of care? I think those are reasonable questions if you are concerned about that. I think another important thing to do is at the very beginning, at your first prenatal appointment, ask your OB, ask your midwife, what are there things of my medical history and my pregnancy histories that makes me higher risk that might make me want to consider potentially going to a higher level of care, or potentially seeing a perinatologist or an MFM in consultation with their pregnancies. For example, Becky, if you don't mind me sort of bringing up like a little bit of your pregnancy, like we identified some complications very early on with your pregnancy, and we sent you to the high risk doctor almost like in the first trimester, I want to say, of your pregnancy. And so we were able to sort of identify many things that were going on with your pregnancy, and we're able to appropriately treat them and then plan for them. When we did deal with complications, there weren't any like huge surprising complications that we dealt with.
Yeah.
Um,
No, I mean this conversation is extremely personal for me because like I said, I had a baby 5 months ago and my pregnancy was not straightforward. Everything ended up great, but I sort of had like a little complication thrown in at every turn. And it was incredibly important for me to be able to have these conversations with my provider, with Dr. Ghosh, about what are my options. And also, despite the fact that I work in the birth world, despite the fact that my OB was a friend of mine, it was disheartening, and this has nothing to do with you. You think I mean, I think you're amazing, as do the people that are asking if you're accepting new patients, but it's disheartening to see that OB's hands are tied in certain scenarios. There are certain things they can't say in a clinical setting. And that leads into one of the questions that we got that I think was sort of one of the things that we had left to talk about. Where was it? Um, We've gotten so many questions. Y'all have great questions. One of the questions was what I can't find the exact wording, but oh, here it is. Can you please speak more about the options during the gray area during the second trimester? So this specific question says it sounds like if there's a problem, the doctor's hands are tied and the patient's unable to travel to care. Does that mean there's nothing that can be done? What are the situations where that arise? And we've talked about the different variables here, but just to kind of review, what does that look like for somebody who is coming in? I think a good example of this is like their bag of water breaks. They're not yet with a fever, so it's not technically currently life-threatening. What can that look like in a facility like yours, but also what maybe could that look like in a facility that's less equipped to deal with something like that?
That's a great question. And I think you're at the crux of why this is so difficult. I think that is the problem with these laws
Yeah.
because it becomes a hands tied situation from my perspective. If I had a patient who came in, I mean, if they were stable, would it be reasonable for them to leave the hospital and decide to seek care out of state? Yeah. Is there inherent risk to that? Sure. Do I understand why people would decide to do that? Yes. Are there certain situations where I would advise a patient, no, I really think you're high risk enough that you need to stay at the hospital? Yeah, I would. And then I would intervene when I could get to a point where I felt I was legally able to. And that looks different for every scenario. And it's hard. I think people want like really solid examples. That's not how this works.
And that is the problem for everybody listening. That's the problem with also with getting your information about healthcare from social media, because the things that do great are the things that present healthcare options as black and white. And the reality of not just pregnancy complications, but all of healthcare is that there are a million shades of gray. And it makes questions like this really hard to answer, and it also makes them really hard to plan for.
Yeah, very much so. I mean, I should also clarify that if I truly thought someone's life was in danger, there is no doubt in my mind of what to do. If I had someone that was bleeding out on my and in my labor and delivery, and I thought I needed to move forward with getting that to resolving that pregnancy, a termination, whatever we want to call it, that's what I would do. It's all the gray before that is the problem. And when to intervene is always going to be the question. If I have a patient that comes in who's, again, let's say periviable, meaning not yet viable, or like, let's say 18, 19 weeks, and they're bleeding, it's hard to say at what point do I decide to pull the trigger on that, right?
Well, and those are a lot of the cases that we see coming out, specifically as women going to the ER, they're bleeding, they're not being admitted. And I think the narrative around that is they're not being admitted because people are scared to touch them. But
Mhm.
I mean, who knows why they're not being admitted? Regardless, it's questions like these, I think, that really do highlight why these laws are deeply concerning for people.
Right. And there's one question in the chat that's sort of talking about like, what if there's a genetic issue?
Mhm.
That is really a situation that we can't intervene in, even if we know that pregnancy is not viable. Um, those patients would have to go out of state. And again, when we talk about aid and abetting, giving information to a patient about what clinic to go to or where to go to is arguably in that aiding and abetting. So it's it's hard to I mean, it's hard because that's not what it was before. Before I had a printed list of clinics that I gave to patients.
Well, and that means that people are leaving with devastating news with a
Mhm.
relatively short window for managing it. And rather than going home to grieve that and to collect their support network in their area and to work with their provider to figure out what their next plan is, they have to go home and figure that out on their own. And that is extremely heartbreaking. I mean, it's heartbreaking regardless, but then to do that without support is obviously even more so.
Right. And it's sucks, frankly. I mean, there's no sugarcoating it. It sucks not to be able to provide care that you know how to do.
Right.
It 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 is it is care that people will beg you for and you cannot give.
Right. Somebody in the comments said, can you refer them to therapists that you know are on pro-choice directories? I'm assuming they're referring to mental health therapy, is my guess. Yes, she did.
I mean, there are so many resources out there, and um, I one of the things I hope at some point is that there become more support groups for people who are going through these situations. Because I'm not gonna lie, I mean, it makes me feel like a horrible person. It makes me feel like I'm violating the oath that I made when I started medical school. You know, we make this really big, not show, but this really big effort when I started medical school. You know, people think about the Hippocratic Oath, and most nowadays what happens is we don't pull the like Greek oath from way back when. That does not really apply. But I remember very thoughtfully we sat down because when I went to medical school, there was only 40 people in my class. We sat down and like it was very collective. It was sort of what ideas do we want? And I mean, it all goes back to the basis of the Hippocratic Oath, which is like do no harm, do good by your patients. And these laws really do seem to put a handcuff on our ability to do that completely in a way that is meaningful for our patients. And, you know, I am grateful to my patients who sort of see the bind that we're in and they understand, like at this point, people understand when they come and see us that there's not a lot that we can talk to them about. Um, and that's really hard. And again, different OBs may interpret the law a little bit differently. So you might hear some other OB going, oh, well, I give that information all the time. I refer them all the time. And that speaks not to them, but to the ambiguity that are in these laws that are not super clear cut. They're not meant to be super clear cut. And they really do, you know, cause a lot of misunderstanding because they're not exactly clear in what they say. They're clear sort of on the things that you don't need them to be clear about, like what is conception.
Right.
But the as far as like when I can intervene and what can I say to patients, that's where it becomes very unclear. And that's where you might get some different opinions from different OBs. And I imagine if you ask one of my partners or someone else in another part of Texas, they might say something completely different than did. And again, I don't blame them for that, but this is just my interpretation based on sort of my conversation with my fellow partners, my conversation with my sister, who is a lawyer and understands how to read law. And even she's like, well, this is pretty obtuse, so it's really hard to interpret. And so I think that just adds to the complexity of the situation. And
Well, and the punishment is so severe. Like you're making these decisions based on ambiguous information with really severe potential punishments.
right. And I think one of the things that I've seen online, but you know, people being like, well, why don't doctors stand up and just do the thing and then risk that? You're asking us to risk quite a bit, right? Because if we come across these situations that if we did that every single time, all half the OBs would be in jail, right? And from a harm reduction standpoint, I have so many patients that I need to be taking care of.
Right.
And if we were to go against the law, I don't know if that's going to be for the good of healthcare in the state of Texas.
Right. And also, I mean, we don't need to debate whether or not it is fair to ask a provider to risk essentially their lives, right? That's the trade-off is it's like it's jail time, it's fines, it's the loss of licensure, which is loss of livelihood. That is, people don't go into, not to get overly political, but teachers don't go into education because they want to be bodyguards.
Mm-hmm.
Doctors don't go into medicine because they want to necessarily be putting themselves on the line for activism, though a lot of the healthcare providers that I know are very vocal activists and advocates. There's a difference. But I think we're at the point where we can start getting into some questions, and there is a question that I think is really, really relevant to what you were just talking about. Is there anything that you want to say before I start kind of calling out some of these questions?
No, I think no. Otherwise, I'm just going to start saying stuff.
There's a lot that we could keep saying. But one question that we got from Natalie is if you live in the state of Texas and you have a non-viable pregnancy that cannot be legally terminated, can you go to a different state to terminate that pregnancy? We've talked about that. But the follow-up question that she has is, will your provider have to report you or get in trouble if you tell them that you did that?
No OB that I know is looking to throw their patients under the bus. SB8, what I tell my patients is if you are going out of state, be very careful about who you talk to. Someone had mentioned in the chat, like, is the vigilante law still in effect? Yes, that's SB8. SB8 again, to my understanding of the law, is a civil lawsuit if you end up going. It's basically a tattletale law. Like if you go out of state to get a termination of pregnancy, the people involved in helping you with that could be liable for that $10,000 fine. So I think that like no OB is going out of their way to report you. To my knowledge, nobody wants to do that, and I don't think any OB wants that reputation either. To my knowledge, I have patients that have seen me pregnant, then I saw them at some time in the future, and they were no longer pregnant.
You're not going to ask.
Yeah, like I mean, we may have conversations, but I'm not out to get my patients.
Sure. Sure. Yeah, I mean that was a great question. Looking at, let's see, other questions. Why don't OBs do blood work early in pregnancies prior to 6 weeks to confirm viability based on levels? Is
Because you can't really confirm viability.
what can
Um,
you confirm prior to 6 weeks?
that you have a pregnancy, that there is a pregnancy. So again, in the state of Texas, it doesn't really matter because a pregnancy is a pregnancy is a pregnancy. So even if there's a heartbeat or there's not a heartbeat, as far as like whether or not finding out genetic information about that pregnancy, the earliest that you can do that is draw that lab work is about 10 weeks and 0 days.
Um, okay, and you touched on this a little bit, but just to clarify, are these laws standard across the board or just in Texas?
There are, I want to say like 18 states that have some level of abortion ban in place. I could be wrong on that number. Do not quote me on that. Texas is probably one of the most strict abortion bans. A lot of places might say more like 12 weeks or 16 weeks. I think the question that has been unasked yet is, can we expect a national abortion ban?
Somebody did ask that and what the impact of that could be.
Um, and so there is a great activist. Her name is Jessica Valenti. I don't know if you follow her, Becky, but I've been following her since my undergraduate days, but she follows abortion on a state by state level. And she talks about how they're likely going to it's going to be called a national minimum standard. And they will not call it an abortion ban. They will label it as something else. And I don't know enough I'm not educated enough in politics to know. I'm not educated enough to know whether or not that would pass. I never thought that Roe v. Wade would ever fall. And maybe I'm just that naive and other people are way smarter than I, but I never thought with Roe v. Wade having been placed, in 1973, I think, I never thought in 2022 when it fell that was never going to happen. So I don't know. And I don't know what a national abortion ban would entail, but I know that it would have devastating effects. And I think the effects that we are starting to see now, the news stories that we're going to see now, are only going to magnify in cases.
Yeah. One, I listen to a podcast on the daily. I'm also not educated enough in politics to have any ability to guess. And similarly, in a million years, if you had asked me in early 2022 if it was possible for anything to happen to Roe, I would have said obviously not.
Mhm.
But I did listen to a really interesting podcast episode from the Daily probably a year or two ago, maybe right after the Dobbs decision about what the fall of Roe was doing to pregnancy rates in the US. And they were seeing a reduction in pregnancy in the states with not just the states with abortion bans, but also other states. And I mean, I know a lot of folks in my circle who were undecided about children, and this seemed to me, I mean, this made their decision a lot easier. They just didn't feel, they don't feel comfortable, they don't feel safe, they don't want to risk it. Um,
Mhm.
and so, I mean, a national abortion ban would be devastating, and that's not even acknowledging the fact that a statewide abortion ban for many people has the same impact because not everybody will be able to travel out of state. There are plenty of people who cannot afford the flight, the time off of work, can't find childcare for existing children, who will never be able to travel out of state. So if we then face a national abortion ban and now we're faced with flying to, I don't know, Canada, Mexico for care, I mean, that would
I
be.
mean, that is exactly what happened previously. If as so as one of the things I mentioned, sort of back at the very beginning, is that I have a minor in women's studies, and at the time, when I went to Texas A&M University, they didn't even have, like, you couldn't even major in gender studies or women's studies. And at the end of my, like, being at A&M, I actually wrote a letter that was like, hey, we should make this a major. Anyway, but one of the things that you learn when you're sort of learning about the history of the abortion movement is that's what happened. People with wealth did fine. They went out of state. They went out of country. They got their abortion. Nothing happened to them. But it was the poor women, the indigent women, the disadvantaged women, women of color. It was those people who suffered the most, and that is my biggest fear: is those people are going to suffer yet again. And it is such a horrible reminder of history repeating itself because we forgot to learn our lesson the first time.
um yeah. Yeah, and I mean our outcomes for women of color are already so much poorer. I mean, to know that inevitably disadvantaged folks are going to be the ones that bear the brunt of this is devastating to a situation that's already pretty devastating and dire. Looking through, I'm so sorry, Daniela. I should have answered this question roughly an hour ago. Yes, the recording of this will be shared. Apologies. I see a bunch of questions about PT related topics. I'm not going to be answering those just because that's not the topic that we're on, but I am looking for other questions. We talked a little bit about complications in the third trimester, like high blood pressure, preeclampsia, and what the range of medical interventions are that are available. Is there anything else that you wanted to say about that that we haven't already touched on?
I don't think so.
This is a good question. Are there any preventative strategies that can help lower the risk or severity of conditions like preeclampsia?
Yeah, this is a little bit off topic, but I think anybody who is concerned about potential pregnancy complications should be talking, especially in regards to preeclampsia, should be talking to their obstetric care provider about whether or not they should start a low dose aspirin. Low dose aspirin has been shown to reduce the rate of preeclampsia. It does better is reduce the rate of, to my understanding of the data, is reduce the risk of severe preeclampsia, meaning preeclampsia that either leads to HELLP syndrome or has severe range blood pressures, the kind of preeclampsia that requires magnesium. It's not 100%, but it is something that you can do proactively. There's no other supplements that we know of that will do that. Like they've looked at things like vitamin C and other like low salt diets, and they've looked at things of that nature. But taking the low dose aspirin is probably the most important thing you could ask about, and see whether or not that is worthwhile for you to take during your pregnancy. The threshold to start people on low dose aspirin is pretty low. So if it's your um, first pregnancy, that's considered a mild risk factor. And if you have that plus literally anything else, that might push you into that category of starting a low dose aspirin. So I would talk to your obstetric care provider if that's something that is worthwhile for you to start. I start many of my patients on that, and it's very much being recommended by the high risk OBs, the perinatologists.
Yeah, shout out to you for starting me on low dose experimental fix. Um,
Uh-huh.
so this is a question about genetic testing. So regarding DNA testing, can you get a false negative? You talked a little bit about how if you get results, you're sending folks to MFM for further testing. Can you get a false negative?
Yes. So I'm going to try to simplify this as best that I can. So the genetic testing that you get, the cell-free DNA testing, refers to DNA that is in your bloodstream that is coming from your placenta. Okay. So as many of you guys may or may not know, it goes baby, umbilical cord, placenta, uterus. Okay. You do not share a blood supply with your baby, but you have a placenta that interacts with your uterus. And what happens is some of the cells of the placenta die and burst open. The normal process. Okay. What that does, though, it releases some of the placental DNA into your bloodstream. Then we take your blood, we separate your DNA from the DNA from the placenta, and we look at the placental DNA and we go, wow, there's more chromosome 21 here of the placenta compared to the other chromosomes. And that's how they get sort of this like high risk for Down syndrome, because there's more chromosome 21 in the sample. And this is a gross simplification of the science. Okay.
That's
Now,
pretty over my head, so that is fine.
so essentially, we're getting information about the pregnancy from the placenta. We are not getting information from the baby. And why that matters is because biology is weird. You can get DNA that is different, like the placenta can have a different DNA, like DNA, genetic makeup compared to the baby. And so you might have a genetically normal placenta and a fetus that is genetically abnormal. And that's one of the reasons why I tell patients, I say from when I do my counseling, I usually tell them like, hey, a negative result is reassuring, but it's not 100% because the most accurate way to look for genetic abnormalities during pregnancy is by doing the more invasive testing where you're actually getting into the pregnancy itself and testing the chromosomes from the fetus.
Okay, thank you. Um, okay, let's see. We talked about in the event of one of these trisomies, if the heartbeat stops, can a DNC be performed?
Mm-hmm. Yes.
Um,
Unequivocally, yes.
I'm looking through, let's see. Does the Texas law allow a doctor to intervene at the ER if someone is bleeding due to miscarrying at home?
Yes. You know, again, if there is no heartbeat, there's no question. There shouldn't be a question. Like I said, these laws are ambiguous, so I can understand why not all physicians know the intricacies of how it's supposed to work. But if there is an active miscarriage going on, and let's say you have an incomplete abortion, meaning you have a pregnancy where some of the tissue has passed, but not all of it, then yes, it is my obligation to make sure that I take care of you.
And just for folks, I'm gonna just acknowledge that we're gonna be answering questions that are really related to the topic that we discussed today. So I am skipping over other questions, other legal questions, other PT questions that are just outside the scope of this conversation. I think they're excellent questions. We're just not the ones with those answers necessarily, and PT is just not the topic for tonight. One question is, would you need to check for cardiac activity before providing abortion care?
In the state of Texas, you cannot do any termination of pregnancy. So the answer in Texas is no, because I can't do it regardless. So let's say that you have a pregnancy that was unintended and undesired, and you were 5 weeks pregnant. There was a pregnancy intrauterine, and there was no heartbeat. Prior to the fall of Roe, prior to the Dobbs decision, yes, you could intervene at that point.
Mhm.
After Dobbs, it's after anything after conception is considered a termination of pregnancy in the eyes of the law.
We talked about federal abortion bans. I'm just looking through other questions. There's an emergent situation before viability, such as water breaking prematurely or cervix dilating, what treatment options are available to protect the patient from becoming ill, septic, hemorrhaging? We talked a little bit about that. Are antibiotics routinely offered to patients to prevent infections? In these pre-viability scenarios, can antibiotics be given to a pregnant patient before an infection starts, or does there already need to be an infection present?
That's getting into some weeds of medicine.
Okay.
That's getting into some complex questions that the answer is complex and dependent on the situation. And this is when I would phone a friend and talk to my high risk OB colleagues, my perinatologists.
Sure. Um, this is a great question. If I go to a smaller OBGYN practice, I'd be asking them if they have connections to these larger hospital networks for potential high risk scenarios.
I don't think it's wrong to ask those questions. I mean, I think that's what I would do if I was in a rural area that was remote from a higher level of care hospital. And I think a lot of people don't know what kind of I think people think a hospital is a hospital is a hospital, but that's not how hospitals work. There are different levels of care. Some hospitals don't even have labor and delivery or even an OB on staff. So oftentimes these are being managed by ER physicians who can't even, who are not, they're not supposed to be managing some of these situations. And they like, and I think again, that's where some of this like complexity comes is people trying to deal with these situations that they're not exactly sure how to deal with.
Sure. I mean, and you would imagine the average ER physician is not well versed in the legality of these
Right.
things.
Exactly.
Is Dr. Ghosh accepting new patients?
I certainly am. The one thing about my practice is that we practice collaboratively at my practice. So I work with five other amazing OBs and two amazing nurse practitioners, and our patients typically will see all the different OBs in our practice for their pregnancy.
One question is, I'm trying to summarize it. Somebody is saying that they asked their OB about these kind of questions like these, and they got really vague answers. And they're asking, do you share what you're sharing right now with all of us, with your patients if asked?
I do. I mean, I did a visit recently with a patient who had these questions and was like, "Hey, she asked me, sir, what does pregnancy look like?" And I, I personally feel like I can speak to them. I don't think I'm telling you anything here that I would not tell my patients in person. Like obviously lengthier time, and I have a much more limited time to talk to patients about this. But I think that it is worthwhile if if you are not pregnant and considering getting pregnant and are considering a certain OB for your care. I think it is reasonable to have what we call a preconception visit. I do preconception visits all the time. I mean, for like people who are like, hey, how do I get pregnant? What do I do? What prenatals do I need to take? What do I need to consider? And so part of that discussion is, all right, let's go through your medical history. Let's go through your period history. Let's talk about what getting pregnant looks like. And if you have concerns about what a pregnancy looks like in a state where your termination options are limited, I think that should be brought up because I think that you're part of our counseling is sort of what that would look like if you ran into those scenarios. And your OB is not going to be able to answer every scenario that could potentially come up because there are a million of them, which is why most OBs don't believe these things should be legislated because there's an infinite number of situations that could potentially happen. But I think your OB can give you an idea of how they have typically dealt with these situations because I would guess that most OBs, at least at some point, has come across some sort of situation that bumped up against one of these laws.
And we are getting close to the hour and a half mark, so I am maybe going to pull out one or two more questions if that's okay with you.
Yeah.
I saw a question somewhere. I wish that I could control F these questions about medication and what the likelihood is of medications like Cytotec and Miso being, where is that question?
Is it with the news logs coming? How do you see the limitations of certain medications like cytotec, misoprostol impacting labor and delivery and handling medically necessary inductions and hemorrhages? I think that's a good question that I don't know if I have a really good I don't really have a really good answer to that. I think one of the concerns was that in I think it was Louisiana, they wanted to make a cytotec be under lock and key, which is hard because in pregnancy we use misoprostol for inductions, oftentimes for cervical ripening to help increase the likelihood of a vaginal birth by ripening the cervix. And we use it in much, much, much higher doses. In fact, doses similar to that we would typically use in miscarriages and terminations with hemorrhages. And I do want to sort of, from a fear standpoint, am I super worried about that? No, because even if they put it under lock and key, misoprostol is kind of your insurance policy for any L&D nurses that are out there. Misoprostol takes about 30 minutes for it to work as a hemorrhage medication. So we give it first because we anticipate it's going to be working later, but we don't. So like if it's under lock and key, yes, I think that would be horrible. But can I do other things in the meanwhile while they're trying to get that from like the Pyxis or wherever they need to get it from under lock and key? Then we'd be able to manage that. But do I think that medication should be under lock and key? Absolutely not. Absolutely not. I don't know how that's going to alter labor and delivery, but I also have managed many a hemorrhage without it. So
Um, thank you. That is helpful. Um, I think that this is probably going to be our last question of the night, unless you see one that you are really desiring to answer. But this question is, what happens with an affected pregnant person who later is asked to give health history with their providers, i.e., how many pregnancies, full term, prior surgeries, complications? Is there an impact on the individual or their providers due to open disclosure with providers and with medical records?
that's a great question. Um, I I I don't know of any laws currently that requires us to submit sort of your pregnancy history to some governing body. So I've had patients tell me that they had a termination out of state, and I put that in their history. Now, if they are concerned about that, the way that we list out pregnancies as far as like terminations and miscarriages go sort of in the same area in your pregnancy history. So like if a patient didn't want me to explicitly put that in their chart, I could do that. I also don't have to put a year of when that happened. Like there's things that I would do because again, your OB is not looking to out you as far as I understand, right? Like none of my partners, for example, are out to get any of our patients with their pregnancies or their terminations. Like that's just not like we are not like trying to get anybody. If anything, we're very protective of our patients. So I don't think that I would be too concerned. Could laws change? Maybe. But as of this point, that's not a major concern of mine.
Yeah. Um, okay. Well, we are officially at an hour and a half. So I just want to say thank you so much for your time. Thank you so much for sharing all of your knowledge with us. I know that this is not a super easy conversation to have, and I know that you even had concerns of how to say things, how to ensure that you're saying things the right way to not put yourself in jeopardy, put your partners in jeopardy. So I'm just really, really grateful that you took the time, and I know the energy to have this conversation. Obviously, this is information people wanted. We had more registrants for this webinar than I've ever had for a webinar for any topic. So clearly this is really needed information. I'm just really grateful for you.
Well, thank you for giving me a platform, and I hope people found this helpful. I mean, again, I know that some of this feels like, wow, I wish you would say more. Me too. Me too. I wish I could say more, but I hope this I wanted this talk to be realistic. I didn't want to be too doom and gloom about it. Like I said, my priority and the priority of my group and the priority I think of the vast majority of OBGYNs is your safety. And sometimes these laws seem to be a little obstructive to that. But when it comes down to critical moments, you matter. You are important. You are not just a walking womb to us. You are a whole human being that deserves to be here just as much as your pregnancy does. So I think sometimes that gets lost in all of this when we talk about sort of abortion and whatever. And I think it feels very raw right now, and people feeling like they don't matter. And to me, you matter so much, and my patients matter so much. And while I at times am frustrated and feel handcuffed, you as my patient and you as women and you as people who have uteruses are so important. And we are going to continue to fight to make you a priority. And what that looks like for every OBGYN is going to be different, but know that we are fighting and we are trying to do our best to do what we can to keep you safe.
Thank you so much. I know that I, as your patient, very much personally felt that and appreciated it. And I know that your practice does literally everything within their power, as I know you do too. And we really need people like you doing what you do. And I know that it is not an easy time to be an OB. So I'm incredibly grateful for the effort and just for all that you do, truly. So thank you. And thank you everybody for joining us tonight. We will be sharing a recording. Give me a day or two to figure out how we're going to host said recording, but we will get it to you in the next couple days.
All right.
Hope everybody has a good night.